Good evening, everyone. I hope you're all well. My name is Darwin Chimba. I'm the Director of Operations for Association of East African Neurosurgeons. So today we have another episode of our Neuro Oncology case presentations that has been running now. Another presenter today, who's also a member of the Association of East African Neurosurgeons, who's going to introduce himself very soon. So I'm going to ask everyone here to introduce themselves. So I'm going to start with Dr. Chibuekem. You can please introduce yourself.
Good evening, everyone. My name is Chibuekem Kwebwen, medical doctor from Nigeria and research fellow at AFAN. It's lovely to be here. Thank you.
Thank you so much, Dr. Chibuekem. We are happy to have you here. Then we have David. You can please introduce yourself.
Hello, everyone. I am David Urujdali from a Russian medical student, equally head of communication at AFAN and research associate. Thank you very much.
All right. Thank you so much, David. So David is the one that is behind the editing of the videos that we post on our YouTube account. He does a very good job. Thank you so much, David, for that. Then we have Musakanya Shituluka. Can please introduce yourself.
Good evening, everyone. My name is Musakanya Shituluka, a fifth-year medical student from Copperbelt University, Zambia.
Thank you so much, Musakanya. Happy to have you here. Then we have our senior in our midst. Very happy to have him here. Dr. Yuk, you can please introduce yourself.
Yeah, thank you. I'm Dr. Yuk Dokon from Benin Republic. I'm undergoing neurosurgical training in Morocco at the WFNS Training Center. Thank you.
Thank you so much, Dr. Yuk. So lastly, we are going to have today's presenter who's going to introduce himself and straight go into the presentation. Praise, you can please go ahead. Thank you so much.
Okay, thank you, Darwin. Good evening, everyone. I'm Wah Praise, fifth-year medical student from the University of Buea, Cameroon. Thank you. So as I earlier said, I'm Wah Praise, medical student from University of Buea, Cameroon. So today we'll be presenting the 8th Neuro Oncology case presentation. Okay, so today I'm presenting a 43-year-old female who presents with a left-sided non-pulsatile tinnitus and progressive hearing loss for 1 year, causing difficulty using a cell phone. She denies vertigo but has mild loss of balance with quick head movements. Her past medical history is otherwise unremarkable. There's no family history of hearing loss, brain tumor, or neurofibromatosis. On neurology exam, she had normal mentation. The extraocular muscles were intact, no facial hypoesthesia or weakness. The Weber test lateralizes to the right. Air conduction is better than bone conduction on Rini tests bilaterally. There's a full aid, non-nystagmus or incoordination. No rotation on Fukuda testing. So on the head, ear, and nose throat examination, there's no dysmorphic features suggestive of syndrome of hearing loss. The ear canals are clear and normal tympanic membrane. On skin examination, no neurocutaneous stigmata such as Cafe-Ule spots with neurofibromatosis, albinism with Waardenburg syndrome. So this is the case we have today. We have had it like it was shared in the group like for the past 1 week. So I would just like each and every one of us to meditate on it now and then. Anyone who thinks of a probable diagnosis for this can raise their hand up and the floor will be given for him to talk. So I hope everybody's getting me.
Yes, we can get you. We can get you.
Oh,
Yes,
okay,
we're
okay,
getting.
okay. So so after reading this case, what do you think of as a probable diagnosis? Anybody can talk. So we have a 23.
Do you want like the diagnosis or just ideas on what should be the diagnosis, or you want the actual diagnosis?
Ideas on what could be the diagnosis. Anything that you have, you can talk on. Yes, we have
Okay.
a port. Yeah,
So
I'm getting you.
I'll be thinking of when I look at the progression of the symptoms, it occurred
Yes.
over 1 year. So I'd be thinking of a benign tumor. Then there's also hearing loss and mild loss of balance. So the tumor is most likely coming from the 80th cranial nerve, the vestibulocochlear nerve. So my diagnosis would be acoustic neuroma. Yeah.
Okay, yeah. Thank you for that. Any other person with a suggestion?
She's right. You can think of acoustic neuroma, and you can also think of neurofibromatosis. Also think of any kind of tumor can arise from the cerebropontine angle, or that can be from the posterior part of the laser wing of the greater wings. I mean, that can extend to the cerebropontine angle. There are some issues, there are some certain things that we need to take into account to eliminate some diagnoses. For example, the case that have been presented was telling us that in the skin part, there's no neurocutaneous stigma, no cafe au lait spot with neurofibromatosis. So that means we can just remove neurofibromatosis type 2. And at the same time, even if the test wasn't precise about this neurofibromatosis, if the patient was having more like type 2 neurofibromatosis, that means in this patient, we will have some other associated tumors in some other part of the body, or the symptoms should be bilateral. But in this patient, is only one side. Only left-sided, no pulsatil tinnitus. So if it was type 2 neurofibromatosis, so it should be bilateral. So that's not the case, and we don't have cafe au lait spot on the patient. There's no other tumor associated, so we can off that possibility of type 2 neurofibromatosis. The remaining tumors are all tumors that can appear, that can extend to a cerebellopontine angle, like neuroma, meningioma, of course, schwannoma. Of course, schwannoma also can be there. So, as possible diagnosis, we can look up those cerebellopontine angles, because in this cerebellopontine angle we have this ongoing nerves, which is the vestibulocochlear nerve. So any tumor like in the meningioma, neuroma, can at that level will compress that nerve. Because this schwannoma, that is a possibility. Okay.
Okay, doctor. Thank you for your contribution. Yeah. Any other person who thinks otherwise? Okay. Without further ado, then we'll move to the various differential diagnosis we can have in this case. So as infectious causes, we can have a conducting hearing loss from otitis media. We can have a tympanic membrane perforation from otitis media, post-meningitis hearing loss. As a neoplastic causes, we can have a vestibular schwannoma, a cerebropontine angle meningioma, and the osteoma of external auditory canal. As a idiopathic causes, we can have a Meniere's disease, osteosclerosis, presbycusis. It will also be traumatic, and lastly, for the autoimmune causes, we can have central hearing loss from multiple sclerosis. So after being presented with this differential diagnosis, so we have an idea of how we can do to rule out the differential diagnosis.
Sorry, before we go to that.
Yes, Darwin.
Yeah, maybe even before going to the investigations that we can do, maybe just from the history itself, or rather from the clinical presentation, I think there's some things that we can probably eliminate. For example, if you can just go back to the previous slide, where
Yes.
we had the other, yeah. Okay, so past medical history is otherwise unremarkable. So if you think of under infectious causes, if you think of
Yes.
post-meningitis hearing loss, right? In the past medical history, or rather in the history and clinical, like on the clinical presentation, there's nothing really that is pointing us so much to the fact that this patient might have had meningitis in the past, because the past medical history is sort of unremarkable. Then what else? Yeah, so there are other things that if we are to scrutinize the history and the physical examination, we would still find that there are some of the differentials here that we may actually exclude even before we go to the investigations. So one of them is post-meningitis hearing loss. I really think we can exclude it just at this point from the fact that there's no indication that the patient had meningitis.
Yeah, you're right. That was even what I was doing just from now. I was like comparing and removing some diagnosis. Like you can see, there's no trauma in this patient, so there's no traumatic diagnosis that can be retained. And it's been said in the test that there's no spot on the skin, nothing is found in this patient on the skin. So you can take out also the autoimmune possibility of the autoimmune reaction. So we will be left with the neoplastic and idiopathic. I think that will a little bit narrow on our window of differential diagnosis.
Yes, doctor. Yeah, looking at it, you will be left with the neoplastic and idiopathic causes. Yeah. So for the neoplastic causes, we have the vestibular schwannoma, which is actually what we are thinking of. Yeah, we also have a cerebropontine angle meningioma, which is also possible, and also an osteoma of the external auditory canal. But I think this one is less likely, because osteoma is a benign tumor of bone, where a bone will go in next to another bone, like the three bones of the middle ear. A benign tumor of bone can occur there, but this is less likely, since they told us in the history that the ear examination was normal, nothing abnormal was found there. Yeah.
Dr. Chibuike had his hand up.
Okay.
You can go ahead, Dr. Chibuike.
Hello?
Yes, Dr. Chibuke, we are listening from you.
Yes. So I don't know if we already excluded the conductive hearing loss from otitis media and tympanic membrane. From the history, it sounded like he had a left-sided sensorineural hearing loss.
Yes.
From the Riley and the Weber stress combined together. So I think we can exclude the conductive hearing loss and then tympanic membrane reparation.
Yes, doctor. Yeah, we have excluded all the infectious causes.
Okay.
Yeah. So now we are tackling now the idiopathic causes, which it could be okay. The first one is a Meniere's disease, and Meniere's disease is also known as endoleaf hydrops. That's and it presents with vertigo, hearing loss, and tinnitus in a similar manner as a presentation we have here. But I think this one will be less likely since the patient does not have complaint of vertigo, and also the long duration of the patient's symptoms will make this one the Meniere's disease less likely. I hope everyone is okay with me.
Yeah, okay, we're following.
Okay, then the next is osteosclerosis. Okay, osteosclerosis is a disorder in which it causes abnormal hardening of bone and we cause an increase in bone density and bone mass. But this is if it were the case, we will have in one of the three bones of the ear canal would have seen an abnormality during the examination, but that's not the case here. So we can hold that one out. Next is presbycusis, which is also known as age-related hearing loss. That's it is a progressive and irreversible bilateral symmetrical age-related sensorineural hearing loss. Looking at this, our patient is still 43 years old, so I think he's still kind of in the youthful age. And the presentation is usually bilateral, not symmetrical as in our case here. So I think we can hold that one out. So looking at the differential diagnosis, we'll be left with I think the neoplastic causes, and then which are vestibular schwannoma and cerebellopontine angle meningioma. And yeah, those are the two diagnoses we have at stake. So in order to confirm them and finally roll out our differentials, we'll go further to the paraclinical investigations. So we are all okay on this, right?
Yeah, go ahead.
Okay. So on the investigations, what do you think can be done to confirm our diagnosis?
Cerebral MRI should be done.
Okay, yeah, Dr. Higgins, in a cerebral MRI can be done. Usually in the case of when we are suspecting a vestibular schwannoma, it's not really necessary to do the routine workup. So we'll just go to our cerebral MRI that was done in this case, and it showed a densely enhancing lesion, enlarging the internal auditory canal. Hope I'm interpreting it well. Somewhere here, and kind of extending into the cerebellopontine angle. I hope we can all see the lesion on the MRI.
I can't see it.
Okay. Yeah, where the pointer is. This is the lesion, densely enhancing lesion. Yeah, I don't know if Dr. Iges and Chibuike can have something to add here.
Hello?
Yes, doctor.
Yeah, this partial lesion that you are showing, is it T1, T2, or what is exactly? This is an MRI, sure, but which one, where are we? Is it T1, T2, T1 with enhancement? Or what? That's what you should say first of all.
Okay, I think it's T1 with the.
I think it's T1 with injection. T1 Gado.
Yeah, with gadolinium enhancement.
Yeah, gadolinium. Yeah, because T1 ingested. Okay, you can see from what you are showing. That was the lesion. The lesion is showing like it's taking homogeneously. It's taking the homogeneously being enhanced by the injection of the contrast.
Yes,
that's what we can say. For the part of the figure that you showed in that area, there is something that is whitish compared to the other side. That's the. I don't know how to show it from here, but you can show it from that from your slide, from your screen. Yeah,
yes,
exactly. That's it. Yeah. You can see on the contralateral part, there's nothing of such. If you compare the left side with the right side, you can see that it's only on the left side that you have this structure that is coming up and it's taking enhanced, homogeneously enhanced by the injection of of gadolinium. I think that's all we can say with this figure.
Okay, yeah, doctor. Thank you for the contribution.
Pleasure.
Yeah, so our MRI scan have confirmed the diagnosis of vestibular schwannoma. So I'll just go to and talk a little bit about the vestibular schwannoma. Okay. So vestibular schwannoma, there are primary extracranial brain tumors that arise from Schwann cells that are responsible for the myelin sheath that helps to keep peripheral nerves insulated. And since they arrive from the vestibular portion of the eighth cranial nerve. You know, the eighth cranial nerve has two parts, the cochlear division and the vestibular division. Yeah, so the vestibular schwannoma arises from there. It's also, the vestibular schwannoma is also known as acoustic neuroma. Yeah, and they account for 9% of primary brain tumor. So hereditary conditions such as neurofibromatosis type 2 can lead to vestibular schwannoma formation. And it occurs at the frequency of 1 in 30,000 to 1 in 50,000 births, so it's quite rare. So the exact cause is usually unknown, but however, some studies have shown an exposure of loud noise or an exposure to loud noise, ionizing radiation, and to be risk factors for developing this disease. However, there's a growing body of evidence that sporadic defects in tumor suppressor genes may give rise to these tumors in some individuals. Yeah, in particular, loss of mutation of a tumor suppressor gene on the long arm of chromosome 22 is strongly associated with vestibular schwannoma. Yeah, so this is likely the main pathophysiology behind that. So how will patients with clinical schwannoma present clinically? So clinically, a patient will come with a hearing loss, which could be, the hearing loss, 90% of patients will present with an unexplained unilateral sensorineural hearing loss. Yeah, and the loss of hearing is usually subtle and worsens slowly. So the next presentation, a patient could come with a tinnitus. This one is present in about 83% of patients with vestibular schwannoma. Yeah, tinnitus, which is a ringing in the patient. That's a sense of you feel a ringing in your ear. Yeah, it's a hallmark symptom of acoustic neuroma. Though not all patients with tinnitus have acoustic neuroma, and not all patients with acoustic neuroma will have tinnitus. So the next symptom could be balance. Yeah, since vestibular schwannoma affects the balance portion, that or the vestibular division of the head cranial nerve, unsteadiness and balance problem or even vertigo might occur, yeah, during the growth of the tumor. So vertigo, that's the feeling of the like the environment is spinning around you. But in some patients, the remainder of the balance system sometimes compensate for this loss, and in some cases, no balance or no imbalance will be noticed with some patients. Some patients will present clinically with no balance issues. Then the next symptom is a pressure, a feeling of pressure or fullness in the ear. Yeah, and lastly, we have also facial weakness or paralysis. So this mostly affects the 7th and the 5th cranial nerve, and it will cause loss of sensation in the face and facial palsy. So the cranial nerve 7, 5, they are usually affected due to the proximity of the tumor to some structures in the inner ear, such as these nerves. So, and also even during the surgical treatment of this tumor, it's possible to damage the trigeminal and facial nerve. Yeah, some patients will present with headache and advanced symptoms from large tumors compressing the adjacent intracranial structures. Large tumors can also cause intracranial pressure, so the patient will present with signs of intracranial pressure. So as diagnosis, the gold standard for diagnosing for the diagnosis of vestibular schwannoma is gadolinium enhanced MRI scan. Yeah, this is the gold standard because if we use gadolinium enhancement, because if we just go and use the routine MRI scan, it may not detect small tumors, like tumors less than, let's say, 1.5 millimeters. Yeah, you will not be easily visible. So routinely they do a gadolinium enhancement, and usually would have a densely enhancing lesion, as we have here, enlarging into the internal auditory canal and often extending into the cerebellopontine angle, as we saw in the case we just presented. So okay, let's discuss the treatment options. There are 2 types of treatment options, that's medical and surgical. For the first part, the medical option, we can do what we observation, and this is mostly recommended for elderly patients, that's those above 65 years who cannot really support surgery, and we have also in patients with small tumors, you can observe the progress of the tumor, and patients who refuse treatment, yes, we can also observe, and also patients with medical conditions or such as comorbidities that cannot permit them to undergo surgery. So so it has been noticed that over an observation period of 5 years, approximately 2/3 of tumors do not go, and half of patients maintain their hearing loss. But some of the downside of this method is that additional symptoms may arise, yeah, such as tinnitus, vertigo, and disequilibrium. Yeah. So, but around 2/3 of tumors have been shown to regress or not go over a 5-year period. So yeah, it's quite reliable. Then the next method is medical. We have stereotactic radiosurgery. Yeah, stereotactic radiosurgery is a minimally invasive surgical intervention that it makes use of 3-dimensional coordinate system to locate small targets inside the body, in the brain, yes, and it will make use of the gamma knife to either ablate the tumor, do a biopsy of it for examination, but in this case we are making use of the gamma knife to kill and ablate the tumor. Yeah, so, and this method is reserved for tumors greater than 3 centimeters in the widest diameter and without symptoms of brainstem compression, as we can see in the image here. And the long-term control, tumor control rate is over 50%. So after 5 years, 60 to 80% of patients maintain useful hearing loss. So this has made some authors to recommend this as the initial treatment of choice for vestibular schwannoma. So lastly, you can go surgically, and the surgical intervention removal remains the treatment of choice for tumor eradication. So using this method, adjacent cranial nerve should be closely monitored so that they should know the extent of the tumor. And knowing the extent of the tumor will guide us either to do a near total resection or a ghost total resection. Yeah, and the 3 different approaches that are used in the management of vestibular schwannoma we have the retrosigmoid approach, translabyrinthine approach, and the middle fossa approach. They are all shot on this diagram. I will not really go into the details of that. Yeah, but just know that for the retrosigmoid approach, you go behind the ear, and translabyrinthal approach, that's think through the external auditory canal, the surgeon will operate through that area, and the middle fossa approach, they do it's kind of, they operate through the middle cranial fossa to be able to resect the tumor. Yeah, I will not really go into the details. Yeah. Okay, that's all for my presentation of today. If anybody has a contribution or question, you're free to ask.
Hello.
Yes.
May I have 1 or 2 questions that I would like to ask?
Yes.
I would like to know if you are working somewhere where you don't have MRI, but you have a CT scan. It's not possible to see the tumor on CT scan. That is my first question, and my second one is about the treatment. I see that the surgery is the best one to do in the treatment, but I found out that also we may do just an observation to see if there is something which will return in the next years. Is it, without radiation or surgical removable option, is it what we can do in observation to help the patient? That's my questions. Thank you.
Okay, thank you for the question.
You.
Let me go ahead with this question, please. Hi.
Okay, doctor.
Okay. about the imaging, about the MRI and CT scan. First of all, the main thing that we use to have like a to differentiate in the about this schwannoma is schwannoma and meningioma. Most time, so this is the two things. So we need to know that usually meningioma are iso-intense. They have the same density, mostly the same density with the parenchyma on T1 and T2 pari. And they are greatly enhanced after injection of the gadolinium. Meanwhile, this is not the case with the schwannoma. So I don't know if the presenter have some T1 and T2 non-injected session to show, but most time if it was meningioma, it will have been iso-intense on T1 and T2, and will be enhanced by the after the injection. I think that's not the case over here. That's why we conclude with this schwannoma. Now about the CT scan. CT scan, how to make the diagnosis on the CT scan? You can suspect when on a CT scan the lesion is enhanced after injection of the contrast product. That's what I know about these differences about for the schwannoma. If it's a schwannoma and you ask for CT scan with injection, so you will find out that when they will inject the patient, the lesion will be enhanced. Meanwhile, that wasn't the case when it wasn't injected, and then you can highly suspect your schwannoma with that CT scan, knowing that the clinic is very important. So you have your clinic, you have the signs and symptoms of the patient. You are thinking of something must be somewhere in this area of cerebropontine angle or somewhere in the vestibular area. And then we've talked about it just now. You now your diagnosis. You see yourself with only few diagnoses like meningioma or schwannoma. On the CT scan, schwannoma is enhanced by the injection of the contrast. Thank you. The second question was about the
treatment.
The treatment, yeah, the treatment. Yeah, the treatment depends on the size of the tumor. You know, so I think if the size is less than 10 centimeters, so we need to follow up this patient, and I don't have the how to say. I think it's 10. It's 10. I don't know if it's, I think it should be if it's 10 centimeter cubic or less than 3. It's okay. It's a lesion of 1 or 2 centimeters of diameter. So that lesion can be followed up. You can follow the patient. And the patient can some patients in 50% of cases, some patients can show improvement or they don't improve at all. They are not worsening. You can just follow up this patient and give some appointment every 3 months or 6 months and do an MRI once in a year to see if the tumor is growing in size or not. But when you have a patient with the schwannoma, it is up to 3 centimeters in diameter, this lesion needs to be treated. And the gold standard, the first treatment that is recommended, with what we do over here in Morocco, the first treatment is the stereotactic radiosurgery. So we send the patient to the center of stereotactic radiosurgery. When the diameter is about 3 centimeters, and then they carry on over there, irradiate the patient with a good outcome. I don't know if I've answered your question anyway.
Yeah, thank you so much. Now I understand very well.
Yeah, thank you. Yeah, thank you, Dr. Higues, for the contribution.
My pleasure.
Yeah. So please, anybody, other person with a contribution or question?
Yes, I have a question.
Yes, we are listening to you, Musakaya.
Yes, you said that the vestibular schwannoma was arising from the vestibular portion of the eighth cranial nerve. So I
Yes.
wanted to find out how it was leading to the hearing loss. I think I didn't get your explanation.
Please, can you come again?
Yeah, you said that acoustic neuroma was arising from the vestibular portion of the vestibulocochlear nerve, right?
Yes.
Yes, and then on the symptoms, you also have the hearing loss. Now, since you said the tumor is arising from the vestibular portion, how is it leading to hearing loss and the tinnitus?
Okay. I think basically the tumor can increase in size and compress the auditory nerve. That's why we call it a sensorineural hearing loss.
Okay, so is it possible to have an acoustic neuroma without hearing loss? They could just have a loss in balance?
Yes, it's possible. I think it's possible because the hearing loss is only present in 90% of cases. That means the majority will have hearing loss, but not actually all. Or not.
If it's a schwannoma, maybe hearing loss in the most of cases. If is another tumor that is extending to the cerebellopontine angle, like a meningioma or neuroma, then it might not be hearing loss, but the patient will show up with the gait disturbances. Okay.
Yes, doctor. Thank you.
Since the schwannoma
Yes, thank you so much.
the schwannoma is the nerve itself that is the origin of the tumor when in case of schwannoma. So definitely in most of cases there will be hearing loss, tinnitus, all those things. But if it's another tumor like meningioma or neuroma coming from ascending to the angle, cerebellopontine angle, so that means the eighth nerve might not be compressed, you know. And it will go on with some other disturbances like disturbance. I don't know if it makes sense to you guys what I'm saying.
Yes, it does. Thank you.
Okay. Yeah. Thank you, Master Kanya, for your question. So yeah, if anybody has a contribution, you can still add. Okay, I think all is well understood. So Darwin.
All right. Thank you so much, Wah Praise, for this great presentation. It's really been on point, and I've learned a lot. And thanks so much to everyone that has contributed, and the questions that came through. They've really made the presentation even more interesting. So thank you so much, and please join us again after next week. I think next week Saturday we're having a presentation by the young Continental African Association of Neurosurgeons. So we're not going to have a presentation for AFAN next Saturday. So please join us. So I'm going to end the presentation. I mean the recording here, and then I just